is Dr. Amit Shah, is a Chief Consultant Anesthesiologist at Kailash Cancer Hospital and Research Center. He is a Director at Vadodara Institute of Neurological Science. He is a General Secretary of All India Difficult Airway Society. He is a Chair Training Committee of International Airway Management Society and the Course Director for Fellowship of Advanced and Difficult Airway Management.
So, thank you, Chairperson. Thank you, organizers, for giving me this opportunity, and we are approaching afternoon. I have 2 minutes service. Still good morning. So, what I will be discussing about the difficult airway and some new way we can call the difficult airway and some innovative approaches. So, let me ask you, all of you must have, okay, I did that. So, all of you must have faced difficult airway, is that right? Okay. Now I am going to make a provocative statement here. I don't think, in my opinion, difficult airway exists, though you have faced difficult airway. Why? Because difficult airway is a context sensitive. This is not my statement. This is by Dr. Hans Schuting, who actually also was part of, he has published an article in our IJ very recently and at a podcast. What he says? That it is context sensitive. That means a difficult airway for me may be not difficult for others, or if it is difficult for me, it may not be at my speed. And term difficult airway itself has a lot of confusion. Why there is a lot of confusion? Because of various reasons. The difficult airway definition itself is not very clear. There are different ways same patients can be managed. We always see 4 different types of options. Prediction models, if we can predict, are not sensitive. And so far we are only evaluating the anatomical difficulties, we are not thinking about other things. So let us go to the definition, which is, this is a very popular definition by American Society of Anesthesiology. I want you to draw attention to 2 things. Experience by a physician trained in anesthesia care. That means you can turn this only after your experience, not before. And what about the other people who are intubating? Can it be difficult for them? So the definition itself has some problems which I think creates confusion. History of previous difficulty is one of the most important consideration in prediction of difficult airway. Accurate documentation is a very important aspect. Are we documenting? You must have faced difficult airway. How many times you have made actually an attempt to identify, and then is it standardized? That means what you are writing, is it possible for others to understand? You might write in a way, so it is not standardized. So documentation is not standardized. On top of that, there are inter-observer variability. That means if you ask 2 persons about cornea, they will have a different answer. And we are not using it. That means for video laryngoscopy, cornea may not be a correct way to express it, but still they are using it. So if your input data are incorrect because of improper documentation or imprecise scoring system, the outcome of prediction model will be unreliable. There are many ways same airway can be managed. Just give you some examples. Pre-oxygenation, the durations can be different, the FiO2 can be different, the flow can be different. You can use closed circuit, you can use open circuit, DPF device, and so many things. You look at the inductions, there are multiple choices available, multiple types of drug, multiple ways you can do it. Bag and mask ventilation, there are so many options, including different types of airway, different types of holding the mask. We already know about direct laryngoscopy and video laryngoscopy. There are multiple choices, and all have different implications. Endotracheal tube, intubation aids, there. At every step there are 10 options at least, or maybe more. Supracortical, I think there are 80 types of options. Awake intubation itself has many methods. You can do it from the front, you can do it from the back, you can use video laryngoscope, you can use sedation, you can use it without sedation. Even a surgical, the rest of hair, there are multiple options and you are still confused which one to choose. So, there are many ways a same patient can be anesthetized or induced by different anesthesiologists. Now, the prediction part. If you can predict, we know that if you can predict, we can plan better. But let's look at the predictions which we are doing. Dennis anesthesia based, 1,88,000 plus patients. Difficult intubation encountered in 3,391 patients, 98% were unanticipated. And when they tried anticipating it, only 25% time they were correct, otherwise it was easy. Similarly for mass ventilations, 94% unanticipated, and then only 22% they can predict accurately. So prediction models are not sensitive. Whatever we are predicting, we are not able to do it. It is unpredictable. Plus, the non-patient related factors which we are actually missing. What are those non-patient related factors? Experience of the anesthetist, time pressure, availability of equipment, location. Just imagine a class 1 airway which is managed by an experienced anesthesiologist in the morning versus same patient in middle of night by an intensivist who might be intubating only once in a month or twice in a month. So experience matters, your location matters, your equipment matters. A morbid obese patient discussed yesterday in hands of Dr. Amit, it was not a difficult intubation, but same patient with my friend who is in Dahod will have a difficulty. So your equipment, location, time pressure, all these matters, and plus human factors which we are not trained with, which are the human factors which we need to understand. Once you have a crisis, who is the leader, who is follower, you should have a situation awareness, you should be making proper decisions, you should be making proper communications, and we are not trained well for that particular matter. We know about these issues, right? I don't think that anyone does not aware about this. But how to incorporate these factors into airway assessment to estimate and determine the difficulty. So what we can do, instead of just terming it as a difficult airway, we can consider two types of factors, airway factor and then non-patient related factor. Airway factor can be identified. Again, this is the suggestion of hand shooting to make a basic and advanced airway. So instead of making it difficult, not difficult, you can make it basic and advanced airway. And this non-patient related factor can be incorporated in a complexity factor. I will explain you in detail. Airway factors, most of the time our airway journey is compared to the flight journey with takeoff and landing. And the cockpit is actually considered same as our anesthesia system. For the cockpit, they have an excellent checklist. It is used by people to make sure that aircraft is in proper situation for takeoff to landing. While what we do for the anesthesia, most of the time we rely heavily on our memory alone. There are some checklists, but they are not standardized. Structured and disciplined approach is lacking. I believe that though we know that anesthesia machine checking is very important, but more than 50-70% time, most of the places, it is actually ignored, it is bypassed. We don't check our anesthesia machine that diligently. If we can incorporate a checklist, it will definitely prevent unanticipated events. We can be better prepared, and if there is a difficulty even after that, there are guidelines which are there which helps you to come out of that particular issue. So what would be your airway checklist? So what we can consider in airway checklist? Yes, patient factors, then the history of the airway assessment, which right now we are only doing that part, the surgical procedure, and the evaluation of vital signs. So this can be considered as a phase checklist. Okay. So what would be the components of phase checklist? Patient factors like ASA status, age, whether patient is cooperating, uncooperating, and so on. History, is there any prior history of radiation, chemotherapy, any medical syndrome? Yeah. Can we remove that? Have I done that? Okay. Thank you. This is something which we are doing, airway factors, malam patti, loose teeth, buck teeth. These are the things which are actually we are checking right now. The surgical factors, surgery in the neck, on the airway, or somewhere else. And of course, vital signs, whether your patient is vital state. So once we have this phase checklist, the phase checklist will give us airway factor, which will give us the basic or advanced airway. That means if your patient does not have problem in any of these factors, we can consider it as a basic factor, basic airway. If there is any factor involved, you can have your local institution policy, where you can decide that okay, these two factors we will consider advanced error, otherwise it's a basic error. For hence it is, if anyone issue with this phase checklist, it is an advanced error. Next is a complexity factor. So what is a complexity factor? It's basically a theory or a scientific principle to model and explain the system, where there are four elements: adaptability, interdependence, interconnection, and diversity. Now, I'll just give you one example. If an anesthesiologist has to anesthetize or intubate a obese patient with COPD, respiratory distress, in intensive care unit, he needs to adapt to that situation. He is dependent on other people to help him. He needs a sister to give him the appropriate equipment. So this is a very complex situation. According to this theory, complexity problem is more complex if there are more than one domain where things are abnormal. So advanced error management is a very complex procedure. So what are the complexity factors for our purpose? This was actually complexity theory which was published in a war journal. Okay, so what can be factors for us? Human factors, language barrier, fatigue, stress. If your patient is from southern part of India, he is going to speak in his language and not going to understand that. Experience, lack of skill means I need to put patient intubate in awake, but I don't have flexible intubation equipment or expertise. Location outside the operation theatre, we are not comfortable. Patient factor like chemotherapy, radiotherapy, like prior radiation therapy in the neck, things are going to be difficult. Technical problems, time pressure, rapid desaturation. So we can, the hands shooting and identify this as a health ET checklist. Health ET checklist. So this can be made, you can make your own checklist. And if presence of abnormal factor make it more complex, and if there are multiple factors in multiple domains, we can make it highly complex. So I'll just give you an example, to just understand how to do it. So now surgery is appendicectomy in the morning by an experienced anesthesiologist is going to give anesthesia, location is operation theatre, patient does not have any other issue, video laryngoscopy is also available, there is no time pressure. So this is a basic airway, no complexity factor, perfect, you can go ahead and do. But if same patient has some elements of difficult airway, Malampatti, bucket, now here there is a slight abnormality. Okay, there is abnormality in one domain. When it is in one domain, yes it is complex but low complexity. If you are an experienced anesthesiologist, video laryngoscopy, you can still go ahead. But if you are a junior anesthetist, then you should always think about calling for help. So if you may think that if things are going to be difficult, you may call for more assistance. But if this patient comes at 3 a.m. in the morning, a second year resident is doing, video laryngoscopy is not available, this is highly complex situation. Same patient in slightly different situation. So this is highly complex situation, you definitely need help and special equipment. Even if such a situation occurs with a senior anesthetist, but in the operation he is in the ambulance, this is still a very complex situation and you definitely need help. So on the basis of this complexity, you can decide your need for the assistance. So decision making is based on two things. One is a phase checklist, second is a complexity factor. Nothing is there, fantastic, basic or advanced airway. When you have a basic or advanced airway, what you need to do is use your standard technique. Rarely if difficulty arises, there are guidelines. So basic airway management can be done with basic management techniques by a trained person and in unlikely event of problems, airway rescue is available. If there is any abnormality in a phase checklist or a complexity factor, this would be an advanced airway. It could be low complex or highly complex. So this will require a technique which you may not often use. You will require a specialist team or assistant. So you definitely need assistance and special team, and you need special preparation for it. That is the most important part of identifying whether it is a low complex there is an airway trial. Okay, this is again developed by Hand Shooting. It's a non-profit organization. No conflict of interest. I also paid for it, but if you are a student, it is available free also. Why I am showing? Because it is a very interesting and very intuitive area. So you go through the various checklists, you go through that, and then it gives you an idea that okay, this is a basic airway, and you can proceed. If there is a problem, you can go to the next, that is the health PT part, patient factor equipment, and it also gives you an exact idea what is your difficulty level, what device you will need, what complexity factors are there. So it gives you a very clear idea, a structured approach. Okay, I'll just give you an example. This was the case which we discussed yesterday, right? This was the case in a panel discussion. Let us put it here. Here, patient had airway obstruction, 1 up per degree, BMI more than 30, weight more than 100, obstructive sleep apnea syndrome. It has given a classification. There are 3 complicating factors. It gives you a very clear idea how many complicating factors you have. So it gives you next, what necessary devices you will need, and when I said I need PL. So these are the list of devices which you can go through, and then give you a very clear idea what is your airway strategy, what is the device you need, what are the complicating factors. It prompts you, it doesn't give you that yes you need PL here, you have to decide what you need. But it prompts you that what are the things which you need. And then there is a very interesting concept called circle of life. I'll just explain you what is circle of life. It is basically once you identify the difficulty, okay, you have decided you need assistance. Next is to determine whether you and your team is ready to go ahead or not. That is called fit to fly experience. Okay, fit to fly experience with the help of circle of life. So they have given 5 points which you go through, and then you decide whether you are ready to go ahead with that particular area. So that is fit to fly. Assessment we already identified, phase checklist, health PT checklist, you identified complexity. Do you need help? Clearly, if it is a complex, you need help. Next is a gold standard and alternate technique. Now in this particular situation, the case which we discussed, video laryngoscopy was something which we decided as a primary plan. So do you have technique and device people in this patient? And if it doesn't work, are you going to have a next plan? Like if I fail, I will put supracortical and put fiber optic. Do I have fiber optic ready? I think in that app I said no. Okay. Then the training. So am I trained for this? That's the next important thing. I am trained for this device, I have clinical experience for device, for the technique of my choice. Then you also identify, is there any chances of complications, like hypoxia, rapid desaturation, which occurs, and then I can deal with that. Next is oxygenation. Do I have a technique like I'm going to use rapid oxygenation, nasal airway, I'm going to do mask ventilation. So I know how to oxygenate this patient and give time for the life. And then, if everything fails, am I ready to do rescue? I am ready to put supracortic airway or a surgical airway. Whatever your technique you decide, am I ready to do it? If you say yes to everything, then you are fit to fly. If it doesn't, then it gives you idea, okay, where the problem is. Like complications are not sure, so you need assistance, your gold standard technique. I said that I may need fiber optic bronchoscope, but it was not there. So I am not ready and I need assistance. So if your skill and experience device for every circle, you are ready to go. More incomplete circle, you need more assistance. Now how will this help us? Basically, now we know that there are so many factors to look at it, and most of the time we also know that ourselves, a consultant or a student, likely to forget about it, likely to go ahead without preparation. This gives you an idea to exactly that, okay, you need assistance and you are not ready for it. In fact, there is a very interesting, once you decide to go ahead, there is a very interesting, can I have the audio please? Okay. Position optimized, they ask when you so they ask you that whether you are ready with all these things.
Airway devices ready.
Everything. And then even if you put something So it gives you an idea that whether you are ready to go or not. So app-based airway assessment and planning, it is a quick and gives you a systematic decision-making tool. It gives you immediate risk classification, so everyone knows that things are going to be difficult. It's a standardized approach. You ask two residents or two anesthesiologists, they take you different criteria for their difficulty. So it is not standardized. It gives you standardized approach and real-time support. So to sum up, difficult airway has many variables, we know that. Airway assessment of only aerodynamical features which we are so far doing is incomplete and inadequate. We need to be more comprehensive. We are not considering human factors or factors with non-anesthesia factors, non-airway factors so far into consideration for the difficulty which we need to incorporate. You can define, it's not necessary that you define it as a basic and advanced. You can give your term, you can give accessible, non-accessible. You can still call it difficult and non-difficult. It's not necessary, but that's a nomenclature which is given by Dr. Hans Witting. And then you can use the circle of life for you to understand that you are ready to, or we call it fit to fly this air. Thank you.
Thank you, Dr. Amit. We are not taking any questions from anyone. As such, we are running out of time. So I would like to invite Dr. Nandan Bhai to felicitate Dr.